If a patient is to receive such therapies as chemotherapy, antibiotics, or total parenteral nutrition over a longer period of time, then a central venous application may be indicated rather than peripheral venous access. For patients receiving a complex infusion regimen over a prolonged period, a central venous catheter provides a means of protecting the peripheral vein. If a peripheral IV cannula remains in place too long, or if aggressive solutions must be infused for an extended time, thrombophlebitis may be the result, as cytotoxins, many cytostatic agents, would irritate the vessel wall and cause inflammation. A peripheral IV cannula occupies a large portion of the lumen of the vein, so that the infused liquid remains nearly in its undiluted form until the next venous junction. In contrast, when a central venous catheter is used, the wall of the peripheral vessels do not come into contact with the infused therapeutic agent.
So, ich finde, das ist jetzt Ihre Ernährung.
Total parenteral nutrition is another indication for the placement of a central venous catheter. The relevant issue here is the infusion of large volumes and solutions of high osmolarity. Typically, a patient may receive 2,000 to 2,500 milliliters of nutritional solution, usually together with additional therapeutic agents. All central venous catheters end approximately 2 to 3 centimeters before the right atrium. The advantage of this is that the infusion solutions enter the circulatory system in a region where there's a large and rapid flow of blood, thereby quickly diluting the preparations. In the superior vena cava, there is a blood flow of approximately 2 liters per minute. At a normal infusion rate of 2 milliliters per minute, this gives a dilution factor of 1 to 1,000. Central venous catheters are inserted via the jugular or subclavian vein. Central venous catheters can, however, also be inserted via a peripheral access such as the basilic or the cephalic vein. Nowadays, such catheters are commonly referred to as PICC-line catheters. There are different types of central venous catheters. The Cavafix systems employ the catheter-in-catheter technique. The Certofix systems use a guide wire based on the Seldinger method. While conventional systems require an X-ray to check the correct location of the catheter tip, modern catheters provide the possibility of checking position by means of ECG monitoring, making an X-ray exposure unnecessary. The form of the P wave clearly indicates the position of the catheter tip. A relatively new method is the insertion of a so-called midline catheter. In the vicinity of the elbow, a short catheter is introduced into the basilic or cephalic vein so that its tip reaches to the subclavian vein. Cavafix Cetadin is a single lumen catheter. The set includes the catheter, an IV cannula and the cable for transmitting the ECG impulse. The universal adapter for ECG monitoring, syringes, 3-way stopcock, bandages as well as the usual utensils for sterile procedures are all ready for use.
Herr Lichtenberg, wie besprochen, Sie bekommen jetzt einen zentralen Venenkatheter von mir.
Central venous catheters are always inserted by physicians. The role of the nursing personnel is to assist the physician. The puncture site is copiously disinfected. One must be sure to allow enough time for the disinfectant to take effect. The veins are constricted. The puncture is made here using the catheter-in-catheter technique. Usually it's not necessary to apply a local anesthetic when using this approach. The puncture needle is removed. After taking off the protective cap, the catheter connector is attached to the plastic cannula. The catheter is held lying flat and advanced from within its protective sheath. After that, the guide wire is connected to the catheter hub so that the J-tip of guide wire extends beyond the tip of the catheter. This improves the passage of the catheter through the venous valves, avoids venous lesions, and optimizes the subsequent transmission of the ECG signal. In the protective sheath, the catheter can be advanced or retracted without endangering sterility. The end of the sheath is pulled tight over the ECG socket to ensure good contact with the connection cable. The connection cable is attached to the guide wire of the catheter. The other end of the connection cable is inserted in the universal adapter. Then the ECG unit is switched over to intra-atrial monitoring. As the catheter is advanced, the physician watches the ECG monitor. To begin with, it shows a normal signal. However, when the catheter reaches the right atrium, the P wave of the ECG undergoes a marked change. This permits reliable monitoring of the location of the catheter tip. The catheter has now reached the right atrium. The P wave is clearly elevated. Here once again is a comparison of the two signals. To begin with, the normal ECG signal, then the elevated P wave as it appears immediately following entry of the catheter tip into the right atrium. When this position has been reached, then the physician can retract the catheter a few centimeters to obtain the desired position in the superior vena cava. The ECG then shows that the P wave has once again returned to its normal form. The catheter is now definitely in the correct position. The ECG can once again be switched over to external monitoring. The connection to the catheter is disengaged. The two-piece catheter connector is removed. The plastic cannula is retracted and connected with the catheter fitting. The catheter must be carefully fixated. The transparent plaster allows ongoing observation of the puncture site. The guide wire may now be removed. Not, however, when a subsequent X-ray check is necessary, as with conventional central venous catheters. A test is made to see that the lumen of the catheter is free. The Luer lock connector of the three-way stopcock is attached to the catheter. The steady drip rate shows that infusion is in progress. To guard against jerking of the catheter, a loop is formed and the catheter is fixated in this position. Before infusion therapy is begun, it's necessary to obtain as exact a picture as possible of the hemodynamic conditions. Placement of a central venous catheter, therefore, often occurs in connection with the measurement of the central venous pressure, or is undertaken expressly for this purpose. Particularly for patients requiring infusion therapy over an extended period, but also for patients with acute cardiac insufficiency, pulmonary embolism, hemorrhaging or shock, measurement of the central venous pressure is necessary. The venous pressure is measured in the superior vena cava directly before the right atrium. The blood pressure in the intrathoracal venous system provides information regarding the functioning of the right atrium and the volume situation in the venous system. To take a CVP measurement, the following items are necessary: a thorax sliding caliper with level, a water-resistant marker, and a CVP set. Medifix is a complete system with a manometer scale, manometer tube and an infusion system with three-way stopcock. The central venous pressure is relative to the height of the right atrium. For a supine patient, this corresponds approximately to 3/5 of the sagittal diameter of the thorax or 2/5 of the thorax diameter as measured from below the sternum. The location of this point is facilitated by the use of a thorax sliding caliper. Here once more is a schematic rendering of a CVP measurement procedure. By means of a three-way stopcock, the central venous catheter is connected with a manometer or with an infusion container holding isotonic saline solution. The three-way stopcock is initially opened in the direction of the patient and CVP set to allow the catheter to fill with saline solution. Then the three-way stopcock is switched over to fill the manometer scale. Finally, the roller clamp is closed and the three-way stopcock is opened in the direction of the patient and the manometer scale. The upper end of the liquid column, the level of which fluctuates in synchronization with respiration, indicates the central venous pressure. Preparations are made for a CVP measurement. The set contains all the necessary single-use items. The manometer scale is attached approximately at patient level to an infusion stand. Then the hands are disinfected. The CVP set is sterile. The infusion system is connected with the saline solution. The roller clamp of the infusion system is closed and the infusion bottle is suspended. The connection tubing to the patient is attached at the roller clamp. The manometer tube is inserted in the holder of the manometer scale with the filter end pointing upwards. The whole infusion system must be vented. To do this, the roller clamp is opened and the three-way stopcock is set so as to allow the venting. The manometer tube is filled to the upper edge of the manometer scale. The roller clamp must be closed in time so that the bacteria filter does not become wet. The three-way stopcock is opened in the direction infusion patient. This closes the Medifix three-way stopcock in the direction patient manometer tube. The patient should be briefly informed of the upcoming CVP measurement. The patient is placed in a fully supine position. The pillow is removed. The thorax sliding caliper is used to set the exterior 0 point. The lower arm of the caliper is inserted 3 to 4 fingers above the xiphoid process of the sternum between the patient's back and the surface on which he's lying. The upper arm of the caliper is placed on the upper thorax wall and brought into alignment. The steel pointer indicates the 0 point, which is then marked with a water-resistant marker. The CVP set connection tube is connected to the central venous catheter. For the measurement, the Medifix Manometer Scale is brought into alignment with the 0 point. Because the infusion is interrupted by this process, the infusion pump must be switched off. Not all pumps have a standby mode for this situation like the one shown here. Many infusion pumps must be shut down and then reset when they're turned on again. If one neglects to switch off the infusion pump during the measurement process, then there's a risk of later administering a bolus infusion. In the infusion tube, which is closed during the measurement process, pressure builds up. If the alarm limits of the infusion pump are not correctly set, then this excess pressure may remain undetected. When the three-way stopcock is opened following the venous pressure measurement, the patient receives a large multiple of the intended infusion dosage in a short amount of time. The risk is obvious. It is therefore important to proceed carefully with interruption of the infusion. The three-way stopcock on the venous catheter is opened in the direction of the CVP set. Any infusions in progress are thereby stopped. The roller clamp is opened shortly to flush the catheter with saline solution. The three-way stopcock of the CVP set is opened in the direction of the patient manometer scale. With this system, the blue line of the scale is magnified to a readily readable band. The upper end of the liquid column shows the measured level of central venous pressure in centimeters water column. The level of the liquid column fluctuates with the breathing of the patient. The median value of the minimum and maximum readings is noted. It should be remembered that a single CVP measurement does not provide absolute information about the status of the patient. As a rule, a CVP measurement should be taken every 2 to 4 hours. Only after several readings have been compared is it possible to determine a tendency. If the patient cannot be positioned in exactly the same manner from time to time, or when in a particular instance there's a variation from the standard position, then this should be noted in the patient's chart. Incorrect measurement values may occur in a number of situations, such as with adipose patients, with patients suffering from ascites, and with patients who are breathing against the respirator. Incorrect placement of the catheter will also result in false measurement results. When measurement is finished, then the three-way stopcock on the catheter to the CVP set is closed. For hygienic reasons, the CVP set should remain on the catheter if possible. The interrupted infusions may now be resumed. The care and monitoring of the central venous axis is also a duty of the nursing personnel. Unfortunately, some patients contract an infection at the puncture site. Careful work cannot entirely eliminate this risk, but it is the most important form of prophylaxis. Even for puncture sites showing no signs of irritation, the bandaging should be changed at the latest every 2 days. Immediate inspection and earlier change of bandaging is necessary if the bandage is soaked through, the patient complains of pain in the arm or at the puncture site, or if other signs of inflammation are evident. The puncture site area must be closely inspected. Signs of inflammation, swelling of the skin that is painful when pressed, as well as skin macerations are alarm signals. Because patients often have low resistance, the monitoring of a central venous catheter requires much vigilance.